The broadcast is now starting. All attendees are in listen-only mode.
Hello all, and thank you all so much for joining us today for our webinar, Fiscal and Economic Effects of Medicaid Expansion. My name is Amanda Lambert. I'm the Marketing Event Coordinator here at REMI, and I'll be the host of today's webinar. Today's event will last for about 1 hour, with the last 10 minutes remaining for questions. Our presenter, Sondra Collins, is a senior economist at University Research Center. This is a division at the Mississippi Institution of Higher Learning. It's here where she can conduct research on various economic issues facing Mississippi. Her position at URC allows her to work with individuals at various state agencies in all of the 8 public universities. And without further ado, I will hand the honors over to Dr. Collins.
Hello, everyone. So I'm going to try to get through this. I don't think it'll take 50 minutes, but I would like for you to wait until I get to the REMI part before you ask questions. Other than that, Amanda's going to help me take your questions as we go along. Like she said, I'm Sondra Collins. I put my email address here on the first slide. It's also on the last slide in case you guys want to reach out and ask questions. I'm happy to answer any questions even after the webinar is over. So our office works with the state legislators as they try to decide what policies they're going to adopt. We try to help them understand what the economic impacts of those policies might be. So we took a second look at Medicaid expansion because there were some new incentives. And so we're going to talk about those as we go along. So current eligibility in Mississippi. So current eligibility goes up to about 209% max, and that's with Medicaid and CHIP. I don't have CHIP in here, but birth to 1 year old is 194% of the poverty line, but CHIP takes that to 209% of the poverty line. Same with 1 to 6 is 143, but CHIP takes it to 209. The group in here that you'll notice is the parent and caretaker group. So those are the people who are age 19 and older, who have a child that's in their care, or sometimes even an elderly person or a disabled person that's in their care, and then they fall at 24% of the poverty line or below. And so just to give you an idea of what that income looks like for a family of 2, which would be, the caretaker and the person that they're taking care of, is $382 a month. That's the max that family can earn, and the caretaker qualify for Medicaid. The disabled person or the child will qualify based on the criteria above. All right, so what about under the expansion? So under the expansion, everyone qualifies as long as their income is 138% of the poverty line or below. So currently, like I said, our 6 to 8 year olds are 133% above the poverty line. We only really have to focus on that 19 to 64 year old group, and that's because 65 year olds qualify for Medicare, and that offers them some insurance. So we're going to focus on the 19 to 64 year olds that enroll. And one thing that's interesting, that's different from our currently in Mississippi, as an adult, you have to be a caregiver, disabled or pregnant, in order to get Medicaid. Of course, with the ACA, you don't. And so we get a broader group. So what about finances? So if you understand Medicaid, you know that the federal government pays a percentage and the state pays a percentage. In Mississippi, the percentage that was paid by the federal government in 2020 was 77%. And so we're usually in that 70% or above, with the federal government paying that much and the state kind of paying the rest. Under the expansion group will get 90%. All right, so if you're familiar with the ACA, you know, the first couple of years, which was 14 and 15, the states, well, the federal government paid 100%, and so the states didn't have to have a match at all. And that 100% kind of dwindled down to 90, where it's remained. And so Mississippi would get that 90%. But it's not for the people who are already eligible now, just for the expanded group. The the American Rescue Plan added an additional 5% just for 2 years. There's a box that you guys can't see, but it's actually in my way. All right, so how do we get started? So we collected data from Medicaid.gov to determine the number of Medicaid enrollees in 19 and 20. For Mississippi, that number was 642,000 roughly for 2020, 619,000 for 2019. That's in a state with a population of about 3 million people. And so the increase between 2019 and 2020, of course, was caused by the pandemic. We estimate that the increased enrollment, if Mississippi was to expand, would be about 233,000 individuals in 2022. And we estimate, just if we wanted to look at all the people that are 19 to 64, all the people in the population age 19 to 64 who live in a household with income under 138% of the poverty rate would be 331,000 people roughly. So that's kind of our max. So we go in and try to figure out how much extra it will cost the state. Remember, we work for, or at least adjacent to the state legislatures. So cost is very important to those that are making those decisions. So they want to know how much extra money is the state going to spend if we are to adopt this expansion. And so we estimate that the state will spend about $186 million in 2022. That number goes up slowly over the next 10 years or so. And the way we estimate this cost is we start with 2019 estimate and we see how much Medicaid costs, Medicaid and CHIP together, the program, costs for the state of Mississippi. And we see that costs around $9,000 a person roughly, but that's state and federal combined. Remember that the federal government pays 77% of that. We go through some logical exercises on our end to try to figure out how much it would cost for this expanded group. So remember that the expanded group, they're adults who are not disabled, generally not pregnant, and also, kids care is a little bit more expensive. So we look at our cost of roughly $9,000 a person, and we say, what would that be if we take away some of these extra costs for some of these extra issues that people who are currently in the program have? We follow a couple of other papers, and we come up with a number at around $5,900. And we grow that expense about 2.6% a year, because that's what the Medicaid expenses in Mississippi seem to be growing, roughly. So as much as we want to know how much it's going to cost us to do this expansion, we also want to know what can the state save, because savings is also a very important part of why some people may opt to expand Medicaid. So the first thing is the higher rate that we're going to get for the first 2 years, according to the American Rescue Plan. So it's $302 million. Like I said, this box keeps getting in my way. $306 million in 2022, $316 million in 2023. And remember, it's only 2 years. So after that, that $300 million in savings completely goes away. Now, for the other ones, I'll just give you the 2022 numbers, but numbers for other years are in the paper. So for those who get a disability waiver, we'll get about $15 million in savings for that group. And the way the savings for that group works is the people who are getting a disability waiver right now the state is paying 23% of the cost to keep those people on Medicaid. If they get moved to the expansion group, the state will only pay 10%. And so moving them from the state paying 23% to the state paying 10% gets us about $15 million. Same process with people with a pregnancy waiver, and then a few other waivers. You see these other costs as $43 million. What's really interesting is uncompensated care. So what happens now is a combination of money from the state and federal government goes to hospitals to help them cover the costs of people that they have to treat but can't pay. So people go to the hospital, they have to be treated, but they just absolutely cannot pay the hospital. The state and federal government try to compensate the hospitals to keep that going. So that will save us about $159 million a year. And so that is the biggest long-term savings, right? The 306 and the 316 are temporary. They only last in 22 and 23, but it's uncompensated care costs is going to carry through every year. And then, so in 2022, that's a total of about $513 million in savings. By 2024, though, once those 2-year bonuses are over, it drops to about $214 million. So this is the biggest part of the paper, which is how do we use REMI in this case? So we basically use REMI in 2 ways. We focus on the cost that we estimated and the savings that we estimated. And the costs, we go into REMI and we look at state and local government spending, and we say, okay, we've estimated this cost out from 2022 to 2027 is what we do in the paper. And we're going to subtract that from state and local government spending. So the state and local government is going to have to spend this money on Medicaid. They won't be able to spend it on other things. So we're going to subtract it out and see how that affects the budget and also the state. But we're also going to take the money that we're saving and we're going to put that in consumption demand. So the money being saved doesn't all necessarily accrue to the government. Remember, some of this money is going to just accrue to people in the state. So it goes in under consumption demand. And then we pick things that the demand is going to be for, right? This money coming in from the federal government. So it's basically a dump of money from the federal government that's going to be spent on hospital care, other kinds of health practitioners as people go just to get primary care, some outpatient surgeries and things that people wouldn't have gotten had it not been for the Medicaid. And then what do we find? So what do we find here is an increase in real GDP. I didn't realize these things went to the next line, but we got an increase in real GDP. That's about a little over 1% of what our GDP is in the state. So it's a pretty good increase. We get an increase of employment. We get personal income that goes up and population increases. Now, most of this increase in all of these things is due to an increase in jobs in the healthcare center, about 80%. Healthcare sector, about 80% of all these increases are the direct result of increases in the healthcare sector. In Mississippi, like a lot of other states, we are currently having a difficult time filling jobs in the healthcare sector that we have. And that goes all the way from doctors, all the way down to, medical record input people. It's like the full gamut has a lot of openings. And so we write this with an asterisk saying, if we can fill these jobs, right? As more people get on Medicaid, we're a very rural state as well. So we'll need more professionals in some very rural areas in order for the people in the rural areas to actually have access. And so if they have Medicaid and they actually have access, we expect the employment numbers to look like this. If we can't draw in those medical workers, which is a concern that a lot of politicians have, that we can't pull the workers in, then people in rural areas still wouldn't have the access that they actually need. And this went by much, much faster than I expected. So I'm going to open it up for questions. Questions on any part of the paper. If you guys have an interest in more detail, let me know.
Awesome. Thank you so much, Sondra. I'm going to be waiting for some questions to kind of pull in here. So if you guys want to just ask the little tab that says questions on it, that's where you can ask your questions to Sondra.
And I guess I'll fill in a little bit of detail as I wait for questions. So one of the difficult things for us was kind of figuring out what that expansion population would look like. It's a very conservative state, and a lot of politicians were concerned that we would underestimate. You know, they said we don't want to underestimate how many people will be added to the Medicaid rolls because we don't want to underestimate the cost. So, you know, try to be as reasonable as you can with estimating the number of people. And so what we did was we went through some American Community Survey data, and we looked at what kind of insurance people had who had the income that was 138% of the poverty level or below for their family size. Some people had insurance right through their employer, and those people are unlikely to change. Some people, of course, already had Medicaid because they had some kind of waiver. Well, all of those people get changed over. Some people had insurance through the marketplace, and we assume that they will probably switch over because it's already government-sponsored insurance, I guess. And then, of course, there were people who were uninsured. But we do know that the uninsured people won't 100% commit to Medicaid just because that's never been the case. It's never been a case where 100% of people qualify for Medicaid or honestly any social service type program actually adopt. And so we go through and we look at what other papers have shown us about adoption rates, and we use those adoption rates in our paper to try to figure out the population and try to get as close as we can to, I guess, a real number in hopes that we didn't underestimate, because we want to make sure that we are being as fair as possible and as honest as possible about the potential cost. I have messed these boxes up so much, Amanda, I cannot see any questions if there are any.
Yeah, the boxes on this GoToWebinar is kind of wonky in the beginning. But as of right now, there are still no questions coming in. We can wait another 5 minutes for some questions, and if there aren't any, everybody's welcome to email Dr. Collins your questions, but I will leave it open for 5 more minutes just for questions.
Yeah, especially if you have questions about REMI, how the model works. If you want me to open it up, I can show you. I know the point of coming to the REMI seminars is kind of to see how REMI works. So if you guys want to see that, just let me know.
Okay. So there is a question that came in. Was there any estimated administrative cost to the state associated with administering a large program? Changes to IT,
Yes.
admin staff, etc. Also, could you expand on the decision regarding uncompensated care?
Okay, yes. So we did include administrative costs. We kind of looked at what our current administrative costs were. If I remember, it was maybe like 2.2, 2.3% of the program, something like that. And so we added those additional administrative costs in as well to our state costs before we put that in REMI. And expand on like uncompensated care. So other states have states who have adopted and states who have, I guess, done research on what adoption would look like have kind of said that one of the biggest benefits has been the idea that you don't get this uncompensated care. And so how does that work? Well, when people go to the doctor or go into the hospital now and they can't pay because of their low income, it just kind of becomes a bill. But if that person had Medicaid, Medicaid would be billed. The hospitals will get the money directly from Medicaid, and then the state wouldn't have to pay the uncompensated care fee. Does that make sense, or does it not answer your question fully?
Let me just see. So far, it looks like you did answer the question fully. I will let you know if there was a response back, if she had more questions.
Okay.
And
I would say this, what I said. Okay, another question. Perfect.
You can keep going if you wanted to say something else.
No, I'm just filling in space. Go ahead.
We got some more questions coming in, so we should be good here. So the next one is, are administrative savings or costs built into your model?
The costs are. So we do talk about, like I said, I think it's 2.2, 2.3% additional. Well, let me say, of the total cost, there was an additional like 2.3% or so cost to the state for administration. And so we add that same 2.2, 2.3% to state costs in the model in our paper. So there is an additional administrative cost. We didn't see a place where there would be a savings on the administrative side.
Okay. I'm just reading through the questions. So I do have some more here. Do you anticipate Medicaid enrollment dropping when the national emergency ends? Have you implemented any waiver programs or plan on doing so to address the costs?
So for this particular paper, as we're thinking about the Medicaid expansion, we do anticipate, like in 2023 and even in 2022, Medicaid enrollment decreasing because it was up in 2020 and 2021 because of the state of emergency. Is the state planning to do anything to enroll those people or keep those people enrolled with waivers? No, there is no plan to do that. And I can't remember the rest of the question. Sorry. Can you ask me again, Amanda?
Yep, rest
sure
of the question. Have you implemented any waiver for the programs or plan on doing so?
No, the state does not have plans to implement any waivers to keep people on after the emergency.
I think you answered it fully that time. I think that was the last thing. Next question is, what are the numbers below the GDP and personal income amount? I think it was on the graph that you had previously.
Yeah, let me see if I can get this thing to go back. I was gonna say I'm feeling old now. So below the population number. So it's four numbers basically here. It's the increase in real GDP, the increase in employment, so the number of new jobs we expect to be open. Remember I mentioned that they may or may not be able to be filled. We have personal income, so everybody in the state that's working, the extra money that they will get as a result of this, and then the population numbers. And remember, we're a really small state, so even though these are still relatively small population increases, they are somewhat meaningful in Mississippi.
Okay, and next question is on this graph again, so I'm glad that we came back here. It looks like for the column that says real GDP and personal income amount, are the dollar amounts the amount of change in each as a result of expansion?
Yes. And one more thing that I should note on this. But first, when we use REMI, REMI has a baseline forecast. And so REMI has whatever they expect actually all the way out to 2060, if you can believe it. So they have what they expect the GDP to be, the population, employment, all of that stuff estimated out for us to 2060. When we shock the system, what REMI spits out for us is what we see as the difference because of the shock. And so this is just because of the two changes that I told you in the previous slide that we made into REMI, the change in how much Mississippi has to take away from its regular budget to spend on Medicaid, and the amount that's going to go into the state's economy because of the federal money that's going to come in to the state. And so these numbers are all extra just because of this Medicaid expansion. And also the numbers are actually in 2012 dollars. So they're bigger than what they appear. But 2012 dollars is kind of what the program uses by default and what a lot of economists are still using right now as kind of the baseline for real GDP. So once we adjust for inflation, we're just adjusting everything down to 2012 dollars.
Okay. I'm just gonna say I'm gonna answer this question because I understand what the question is. Somebody was asking what the numbers were meaning below. So for instance, at this chart, how it says that 461603. The reason it's like that is if the cells were expanded more, it would just be.
Yes.
I'm
sorry. That's the question. I wasn't paying attention before I put these slides up. I'll make that one number before I send it back out to Amanda.
Perfect.
It's just
yeah, I can fix that too on my end. So that's all that is, not any crazy numbers. Next question for you, Sondra, is how does inflation factor into this model?
How does inflation factor into this model? So we didn't explicitly put inflation into the model. And honestly, we're probably underaccounting for it. Like I said, REMI has this baseline that goes out to 2060. And it has just like a normal inflation built into the model that's at like 2 point something percent. And so since we've had so much inflation, well, I guess if the inflation continues to be above that in 2022 and 2023 and for more years, then this is actually in a way not counting for that higher inflation. So we already know 2022 is probably going to be higher than the norm. So this number isn't really counting for that higher inflation. I'm trying to think about what that really means. I think it means that the real GDP would be a little bit less because we'd have to deflate it by a slightly bigger number. It doesn't really change a lot as far as personal income and employment or population, but that real GDP, because it is adjusted for inflation, would need to be adjusted for a bigger number in 2022. Inflation keeps going the way it's going this year.
Okay. We do have two more questions, and then somebody would like a REMI demo. So I'm just gonna have you answer these two, and then we can do a quick little REMI demo, and then we can probably wrap it up. So the last two questions are, why do you estimate the cost of previously uninsured individuals that will reduce the cost 2/3 of current Medicaid enrollees?
More time. Why do we estimate?
Why do you estimate the cost of previous uninsured individuals?
So in the paper, when we talk about previous uninsured individual, we're saying, we're saying we was, in theory, we would start the program in the beginning of 2022. And we're looking at people who were uninsured prior to that and moving them into Medicaid. Not everyone is going to adopt Medicaid. So when we look to see what other people have predicted or other states have seen as far as uninsured people actually taking up Medicaid when they qualify for Medicaid, it's like that 2/3 number. Is that the question?
Yes. Yep.
If it's not the question, then if you tell me what page it's on, I probably can maybe answer it a little bit better.
They don't have the page, but the way you answered that sounded correct to me. But if they respond back, I will let you know. The next question is, how do you decide the amount that was extracted from state and local government spending when you run the model?
So we decide that amount by what we estimated. Let's see. So we estimated the cost to the state is 186 million in 2022, and then we estimate that for the next 5 years as well. And that's how much the state actually has to pay extra to the Medicaid program. So that's how much we take out of their spending. So they can't spend that money on other things because they now have to spend it on Medicaid.
Okay. Perfect. And it seems like the previous question was for page 6, possibly.
Okay. When we're estimating costs, in
Yes,
2/3.
I believe so.
I'll see. If that person would just send me an email, I could definitely fully answer the question. So, sorry, I'm not getting it on the fly, but I can answer it if you send it an email. All right. And somebody said they wanted to see REMI.
Yep, if they wanted to just do a quick REMI demo, just so then you can kind of show them what you're talking about.
So I wanted to open up REMI, but it's not on this one. I'm sorry. I just got a new work laptop. I didn't realize I didn't put it on here. But it's really striking out today. It's really as simple as you. Do you have it on yours, Amanda? Do you want to share a REMI screen and quickly show where?
I don't have it.
No.
No, I don't do the REMI demo.
Okay. I would have to switch computers, and it's probably not going to work. All right. Any other questions? The person who wanted to see the REMI demo, if you send me an email, I will send you like a Zoom meeting, and I will show you.
Yes, and the REMI YouTube site has a whole bunch of other demos that REMI models have, and you all will be receiving an email to a link so you can access the PDF slides. Dr. Collins' page she wrote, as well as this recording, and the recording will be on our YouTube page, so you can easily find other REMI demos there as well. But on that, I do think all the questions are answered. Thank you so much for spending your time with me today. Sondra, do you have any last comments?
No problem. Thank you guys for coming.
Awesome. Thank you.